Achilles tendinopathy and rupture. But I got to turn off some of these tunes here in the background. A little bit of Kygo going on. That's always fun. All right, so a couple of key things to get for an Achilles tendon rupture. What do we have to understand? We have to realize it is a chronic overuse condition, typically, of the Achilles tendon. Well, it's in the Achilles tendon, or a deconditioning issue that you might see, partial tear or even full rupture in end stages. Pathophysiology. The Achilles tendon is incredibly strong. Up to 10 times body weight forces pass through it with activity, and you're lifting yourself off on one foot. That is that entire Achilles tendon taking that. Injury occurs when repeated load over time exceeds the tendon's ability to withstand it. So basically, it doesn't have time to adapt. It starts with micro trauma and repetitive tearing, which can also be secondary to deconditioning that takes place. Usually, we see an area of decreased vascularization in this tendon, approximately 2 to 7, 2 to 6, depending on who you read, centimeters above the calcaneus. And histopathological studies show the Achilles tendon degeneration goes through 3 main phases. A peritendinitis, or paratendinitis, I should say, so just kind of an irritation around the sheaths. A tendinosis, where it starts to see changes actually inside the tendons, and then both of those together with small micro tearing and more larger ruptures as you progress through the process. So the person will often come in first with Achilles tendinopathy that can lead to an Achilles tendinitis. Sorry, a tendinitis that will lead to an Achilles tendon rupture, pardon me. And here I am showing the basic progressions of it. A little bit of irritation around the sheaths and the tendon itself, small micro tearing, and then eventually a full rupture. So demographics, who gets this? It is a common injury. We see it in 6 to 18% of runners. I've had a few patients in the office, even within the last month, with full Achilles tendon ruptures. Generally, it is your middle-aged person, and it's going to be way greater in men than women. So 35 to 55 and 4 to 7 times more likely in men than women. So increased risks are associated with increased age, overuse, and poor conditioning. Hey, weekend warrior, what's up? Let's go play some basketball and rupture your Achilles tendons. Higher arch and overpronation also has some correlation in the literature. Tibia varum, varus abnormalities can be there as well. Increased activity too rapidly for the body to adapt to the pressure is there, and low recovery time between training sessions. If you are older, you generally need more time to recover. Change in surface or footwear, so new shoes, running on a harder surface, decreased flexibility of the gastrocnemius and soleus means the tendon takes more force. And interestingly enough, fluoroquinolones, the antibiotics, are associated with tendon ruptures as well. So please be aware of that if you're doing a detailed history. Assessment, posterior heel pain. It may be sharp. It may start off as local pain, even on the gastroc tendon, the Achilles tendon right there. There may be a snapping sensation, or the person may have felt like they were hit in the back of the leg and they heard a popping sound, and then they had sudden pain and loss of function. Rest may decrease symptoms in the tendinopathy phases, and it may increase with activity. In later stages, the pain may become chronic and constant for that person. Inspection, possible mild edema and ecchymosis around the calcaneus. Usually not. If it is, the person's probably rubbing it, or it's probably more advanced in its progression. We can also see possible limited ankle flexion, especially with heel walking, inability to lift their toes up. Palpation, and this is the go-to right here, exquisite point tenderness, 2 to 6 centimeters above the insertion of the calcaneal tendon. Mid-tendon pain is what you're looking at right here. Possible palpable defect or nodules. I often feel this when I'm doing evaluations. If ruptured, the tendon has a palpable gap. You cannot feel it. Or if it's ruptured and started on the healing process, it might feel substantially thicker. In your observation, it might look like it's twice as wide as the other unaffected tendon. Maybe limited plantar flexion and dorsiflexion, possibly. Active range of motion may be limited due to pain. Resisted ankle plantar flexion may have weakness if they can even do it. There may be strength changes for your neurovascular evaluation. Evaluation of deep tendon reflexes. Well, obviously, if the tendon is ruptured, you're probably not going to get much of a DTR on that side. Differential diagnosis. Well, Achilles tendon rupture is going to be there. 20% of Achilles tendon ruptures are missed. I do not know how this happens, why this is written in the literature. How could you miss an Achilles tendon rupture? It seems like one of the most obvious conditions to me to evaluate. Now, maybe if it was a partial rupture, but a full tear of the Achilles tendon, you should be able to pick that up right away. Retrocalcaneal bursitis is going to be a little bit more near the insertion right off the back of the calcaneus. Tibialis posterior tendonitis could be there, but it'll be more around the medial malleolus, and your palpation ability and your basic anatomy will help you get through that. Tibial stress fracture, you can watch the video on it, but generally the pain is not located in the same area. It may be associated with repetitive overuse, but not in the same area. Gastroc strain or tennis leg, just call it a gastroc strain, may be there, but it's going to be more proximal and higher up. Seaver's disease, look for that pre-skeletal maturity, roughly 10 to 15-year-old with pain over top of the heel. Again, not quite the same area. Syndesmotic ankle sprain, look for your mechanism of injury. And rarely inflammatory arthritis like Reiter's, or I should say reactive arthritis. What you're looking at there is usually symptoms that will be bilateral, and they will not usually hear a snap or a pop or have tenderness to palpation over the Achilles tendon. All right, so special test, Achilles tendon squeeze. All this is basic palpation. Ask the person to plantar flex and dorsiflex as you do that. Thomas test, you'll see surgeons always putting this up on their social media. Like, what a great test. Yeah, it is a great test, but you should be able to pick up a full Achilles tendon rupture without this test. There'll be massive swelling. You cannot see the medial nodal malleolus in a lot of cases, poor definition around the tendon itself. Diagnostic imaging is usually not warranted. You know what's going on here. X-rays are not going to help you unless you're trying to rule out another fracture or something. Ultrasounds, pretty good idea if they're readily available in your area. They will show you what's going on. And MRI, usually not indicated, overkill for this condition. Unless, of course, you're looking at surgical evaluation, but even the surgeries are controversial. So if we're looking at this, we can look at what is our treatment going to be? Relative rest. If it is a complete or severe rupture, you can be looking at non-weight-bearing activities and have a surgical consultation. But if you look at the 5 and 10-year outcomes, current best practices suggest that it may not be of benefit to have surgery as part of that process. And more surgeons are opting not to have that surgery done. Now, if you are an elite level player and you can get in for surgery within a few hours or a few days of the actual injury, then we might see different outcomes. But for the vast majority of the population, we are stuck waiting weeks to months potentially for surgical interventions. Limited weight bearing with crutches, a walking boot may be necessary, but progress sooner to allow a little bit of increased range of motion rather than being, I've got one patient that's fresh in my mind right here from a month ago, and he was in a walking boot for 6 weeks in plantar flexion. He had a full Achilles tendon rupture, and that is just too long. It actually resulted in significant contracture of the Achilles tendon, atrophy of the tissue, and he's not healed in a good way because of it. So now I have to battle uphill through that healing process. Massage therapy, once you've reached medical clearance, is going to be a fantastic idea. Contrast, hot, cold is going to be good. Your Swedish techniques with instrument-assisted techniques are all going to offer benefit. You might consider electrotherapies like ultrasound to increase and promote healing in the area. Acupuncture can offer some benefits. NSAIDs for short-term use. Corticosteroid injections are not indicated and controversial. I would steer you away from those. There is a risk of re-rupture of the tendon of approximately 4%, so relatively low, but educate your people on that if it has torn. If you just have tendonitis, identify the aggravating activities. All right, what do we see here? Higher and postoperative complications. Conservative treatment has lower complications, but has a higher risk of re-rupture. So again, make the person aware of that. But chances are if they've ruptured it, they're in their 40s and 50s. They're not going to be extremely athletically active in the vast majority of cases. Rehab program, meth them up. Movement, exercise, and traction are key. Look at applying some heat and passive range of motion. Weight bearing as soon as possible, and that includes full range of motion with calf stretching and strengthening as tolerated, and eccentric loading exercises will be key. There was a story of a surgeon who had Achilles tendonitis, and he actually wanted to have his tendon rupture so he could get the surgery done and get back to work. He was tired of the chronic pain. So everywhere he went, he would actually be like on the edges of stairs, plantar flexion, dorsiflexion. He'd be pushing into the corner of walls, plantar flexion and dorsiflexion. And he would do this repetitively. And guess what happened? His Achilles tendon did not rupture. It actually got stronger and remodeled to the stress. So again, I would encourage you as a basic treatment strategy, remodeling and challenging this tissue more may result in better outcomes, but avoid the overuse or extreme aggravation. Consider orthotics if you need those, or looking at your technique-specific activities. Prognosis in mild to moderate injuries, you can expect good outcomes from it. Stiffness may last for 2 to 6 weeks, but eventually they'll work their way through it. Recurrence is common. especially if you're not evaluating what the ergonomic differences are for that person. You might also look at Achilles ruptures may result in long-term disability in competitive athletes and should be expected to reduce function. And this is one of the things where you really have to educate and empower your people if they are elite level athletes, and that's how they learn a living, with football players, soccer players, all of that kind of stuff. Young athletes with full rupture has a 200-fold increase in having sustaining a contralateral rupture, higher chance of re-rupture on the same side. Okay, so those are two prime examples right there. Now, what I would like to do actually is play a video for you of an Achilles tendon rupture. So let me go ahead and find this for everybody to begin with. Take me a second to find it, so there will be some silence for a while. Videos, injury and trauma, and athletic tendon tears. So here we can go ahead and see this. This is a pretty standard how it happens. The injury actually happens right there, and that's how fast it happens in real life. Most of you did not see what happens, but we can see an elite level player here limping as he is walking around and trying to get his motion back. So if we look at this, you can see all the players coming out and they're going to do an evaluation. I'll zoom forward here a little bit closer. A lot of people look at, let me get back just a little bit. The nice thing about the NFL is there's so many different camera views. So here you can see him. He steps down and then he collapses down. So the commentators are saying he just slipped and went down. Again, you don't get good visualization of the injury here. Same thing here. People see this knee fall and they're like, oh, it hit his foot. Nope, didn't hit his foot at all. It's on the grass right beside him. That is a non-injury as well. But if we look closer, now we're going to see it. Boom. So right there it happened. I'll blow it up again for you. It's a full eccentric load to concentric load. So you got to figure Brandon Oliver, he's weighing right now probably around 220 lean. So this is a powerful, strong guy right here. You're going to see him plant this foot. It goes into full dorsiflexion, full eccentric load, and then he tries to come off of it. Stretch, 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 trying to contract and snap. You can just see the vibration and shake of the muscle as it breaks. Here's another one just for everybody to look at. Biceps tendon rupture, common in deadlifts, non-dominant arm. Okay, so again, eccentric load, snaps the tendon, takes a while for the nervous system to realize it. And that's what happens right there. I got a whole bunch of these great videos. Snap. Yeah, super good. All right, so there we can go ahead and see those injuries. All right, that takes you through Achilles tendon rupture. Thank you very much for your time. Educate, empower, graded activity exposure, appropriate nutrition, and our manual therapies can help walk you through that process as well. Excellent.